Good afternoon, everybody, and thank you again so much for joining us for another one of our wonderful MAG specialist seminars. Today we have a repeat offender, the very, very lovely Dr. Stephen Vincent, who has already done an excellent seminar on us, and there's another one still coming, all on his topics of expertise within his specialty of respiratory medicine. Dr. Vincent is based up in North Queensland, so he sees some very interesting things, but he's across this, across the whole, all things respiratory. I think you'll find him a very, very good presenter, and I think you'll find the information in today's session really interesting. Occupational asthma has taken a bit of a back seat with some slightly more glamorous things going around, but this is a pervasive and long-term condition, so it's really interesting to have this up-to-date information about it. May I ask that you all please remain on mute throughout the session. There'll be a time at the end to unmute yourself and ask questions. The reason for remaining on mute is so that noise in your home or workplace doesn't cause disruption to the quality of the recording. Afterwards, you will get sent the recording within a day or so, and of course you can always watch it on our YouTube channel. So thank you again, and over to you, Dr. Vincent.
All right. Well, thanks again for the opportunity to speak. And as you say, the glamour of occupational asthma has pretty much gone down, sort of to the below the bar, below the threshold of people thinking about it. And there's one particular subtype of occupational asthma which is probably more than the classic occupational asthma that I'll go into, because I think this is probably what you're going to see more, and the sort of long-term consequences of it. So I'll just get started with the talk there. Okay, now I suppose the first question, that everyone thinks is, what is asthma? Because it's something that, to us medicos, it's an easy thing to determine, but it's hard to really define until you look at the anatomy of the lung. Okay, so what we're going to talk about today is, definition of asthma, and I'll go through the background of occupational asthma, what it is, how to recognise it, how to differentiate it from normal asthma, and what workplace mechanisms can give rise to either temporary or long-term occupational asthma, what the treatment is and what the outcome. And then I'll probably just spend a bit more time on a subtype of asthma, which I don't think many people heard about, unless you're in the respiratory world. There's something called reactive airway dysfunction syndrome, which is usually due to one or two significant inhalation events, and it could be anything that's toxic to the lung and can render the patient permanently impaired. And unfortunately, it probably takes about 6 to 12 months before doctors actually realise it. And a couple of work cover cases I've done too, a lot of the lawyers and work cover people haven't heard of it as well, but it's something that's sort of gaining traction, especially in dodgy workplace practices, which unfortunately still occur. And it's usually in people who can't really afford to be off work, and their job involves some sort of physical jobs. All right, now I'll just go into background of asthma. All right, so the airway goes anywhere from the tip of the nose down to the thing called the alveoli, which is the I'll just see, put the laser pointer there. Yeah, so go anywhere from the tip of the nose and all the way down the trachea to the main airway. These are called the main bronchi, and then you've got the sublobar bronchi, then bronchioles, and then the alveolar where the gas exchange occurs. So most of the time you breathe through the nose, and the main reason for that is that there's a lot of particles in the air that you just can't see. So if you had a special pair of glasses on that could actually see the small particles breathing in, you'd probably be horrified of just what we're breathing in normally. So it's a combination of dust, which is usually shedded dead skin, pollens, mold toxins, various chemicals, but these all get hoovered up in the upper airway, in the nostril, and also the trachea. And then they're usually swallowed without us really knowing. But the trouble is that any particle size that's less than 2.5 micrometers in diameter, and that is very small. So if you chop a hair, the diameter of a human hair is 70, which is 70 micrometers. So you can imagine that a 2.5 micrometer object is very small, and that usually bypasses all these defense mechanisms from the nose, the trachea, the airway, and gets into the more distal airways, and that's where problems like asthma and, from a last talk, coal dust and silicosis and all that occurs. Okay, so these are what our defense mechanisms are. So we've got this is in the nose, so we've got hair there. People like to sort of pluck them out, but it's the hair that's inside the nose that's important. So that traps larger particles, and there's a slight mucus layer there which is watery and thick and sticky. And what happens when you breathe through your nose, the air becomes cyclonic, so there's things called turbinates, which are bone structures that cause the air to spin around, and all the large particles fling off to the side, get stuck to the wall. And then down in the trachea and the airway, we've got this what's called a mucociliary trap. So we've got small particles of hair-like structures that sort of wave around like reeds in the ocean, and that's covered with a layer of mucus, and you can see there's a particle there. So anything that's about 10 micrometers in diameter gets trapped in the trachea, the bronchi, and the larger airways, and gets swallowed during the day without you noticing. And the place where asthma occurs is what's called the distal airways, which are less than about 10 micrometers in diameter. So this is a cross-section of a normal normal lung at the 10 micrometer level. So we've got muscle on the outside and this sort of smooth mucosal layer on the inside. Now, what asthma is, it's an abnormal immune reaction to allergens in the air, such as pollens, dust mite, cat proteins, bird feathers, and all the rest of it. And if you are sensitive to it, you get thickened airways. So you can see where the air goes is nice and thick there, but on the asthmatic airway it's fairly narrowed. And during severe asthma attack, say if someone gets a viral infection or has a big load of antigens, such as during hay fever season, it's only a tiny hole to breathe through, and that causes breathlessness. So common asthma treatments reverse this by relaxing the smooth muscle and also reducing all the inflammation. Now, unfortunately, there's some chemicals in the workplace that can actually mimic the asthmatic lung and cause this exact response. And the trouble is there's no real treatment for it. So the pathogenesis of both occupational and normal asthma is abnormal constriction of the smaller airways due to inhalation of tiny particles that we can't see. Okay, so as far as classic asthma, usually it occurs from your immune system getting sensitized to pollens, dust mites, and animal protein when you're young. And over a period of time, your immune system has this thing called maladaptation, where it over-responds to whenever you breathe in these particles. And that causes symptoms such as cough due to mucus hypersecretion, wheeze, which is air moving through abnormally narrowed airways, and cause shortness of breath because you're trying to get air through a very narrow tube. And, this can occur all the time, or if people on treatment, that fixes it. Now, the trouble with occupational asthma is that this can be triggered by tiny toxic agents in the workplace, and the symptoms are quite similar to asthma. And usually in adults, they don't have the classic wheeze and cough. It could be just shortness of breath. And people may not realise that it's the workplace that is causing this problem. Usually, whenever it occurs at the start, it's during the exposure. I'll go through what the exposure agents are, but sometimes it can become more prominent where people are breathless all the time. But classically, when they're away from the workplace, the symptoms settle down on weekends or holidays. That's sort of the classic story. And the treatment's avoidance of the triggers, and in some cases that can be lifelong. And the things that can actually cause occupational asthma is fairly varied. So you've got a common one that we used to see, but not so much anymore due to big paint tents and adequate ventilation, is when people are using two-pack paint. So that you've got part A and part B. So if people inhale the part B while they're mixing it up, they breathe in this agent, which can contain tiny molecules called isocyanates, which is the third one on the list there, that can induce the same sort of reaction in your lung as a classic asthmatic. And it's only while you're using the paint that you get short of breath and wheezy. And sometimes the symptoms are fairly mild and insidious at the start, that people might just think they're short of breath due to, the paper mask that they've been issued. Also, it's not uncommon for people who work in the bakery industry, especially the ones cooking the bread, to get tiny molecules of flour inhaled into the lung if they're not wearing appropriate air protection, and develop asthma from the flour. And also a non-specific exposure to other noxious fumes, such as with other sort of paints and varnishes. Okay. It can also occur in people who work with wood, especially something called Western red cedar or New Guinea rosewood. They're sort of classic things that can bring on occupational asthma. People work in a factory that creates latex. And probably a thing that we're recognising more is welding fumes. So you can see in this picture here, the guy has very good protection from the bright light with his welding mask. But these are the sort of fumes that can be sometimes given off with the welding. So all that smoke there doesn't cause problems in the lung. It's the particles that are given off from the welding that you can't see that can cause irreversible asthma. And believe it or not, people who work in sort of seafood industry, who are sort of cutting and grinding up seafood, there's very common allergens in that as well. So it's a pretty varied type of job description that people can develop occupational asthma, unlike people with, coal miners and sandblasters that develop either black lung or silicosis. You've got a good occupational history there. But this one's so varied, it can be anywhere from bakers, woodworkers, people who work with seafood. And now, as far as the diagnosis goes, people usually present to their GP with a typical asthma symptom. Probably at first, they're just labelled as having classic asthma. But once again, it's, if you go through a good occupational history, you find that their symptoms are typical while they're at work, as opposed to when they're at home, and the symptoms resolve on holidays and on the weekend. I suppose the trouble is that, luckily, not as many people smoke as they used to. It used to be about 30% 20 years ago. Now it's about 14% of Australians smoke. So some people just blame the smoking for it. And if someone has a history of asthma, they can develop coexistent occupational asthma as well. So you've just got to tease out whether it's the work involved or the classic asthma, depending on their exposure to various agents. Now, as far as prognosis goes, it's pretty good with adequate protection, using spray paint booths where the paint fumes are present, so people wear full protection, including their clothes, and there's good negative pressure in there to suck out all the fumes. But unfortunately, sometimes the cases may be permanent, and even if they either get away from work or institute better occupational health and safety practices, they're left with this constant breathlessness long term, wheezing, and they can flare up with viral infections and so forth. And unfortunately, standard treatment doesn't work. So this type of asthma is much less common than it used to be due to adequate respiratory protection. And unfortunately, I guess, really depends on either the GP being diligent to differentiate normal asthma to occupational asthma, and if they're referred to a respiratory physician to try and tease it out. So it's common if we look for people with allergens that they're negative to it, if they've still got asthma, then we think there's some other process. But unfortunately, yeah, people may have to change their jobs because after a while, even a tiny exposure can cause an asthma attack. Okay, now I'll talk about a notable case. So, this is, not, a typical sort of thing. I had probably 2 years ago, a 20-year-old male. He was a non-smoker. He had no history of asthma. He commenced work as a spray painter on the side of boats, and he was issued with a mask. There's one of these paper masks here. So you can see it's got N95. So what that means is that 95% of viruses won't go through the mask, 5% will. So they're sort of more useful for things, for viral protection like COVID and influenza and so forth. But if you've got something that's got a particle less than 2.5 micrometers, it's going to pretty much go through that mask like a sieve, because the viral particles are about 100 probably about 30 micrometers in diameter, whereas the especially in the isocyanates in the paint is about 2.5. So he commenced work as a spray painter, and he was given the protective paper mask. And probably about 10 weeks, he started to develop shortness of breath, and he was wheezy, especially when he was working. And he noticed that it resolved on the weekends completely. He could play footy, he could run around without any problems. But come Monday, he'd be back painting the side of the boat, and the symptoms came back. Unfortunately, the boss wasn't particularly sympathetic to him. I think towards the end, he essentially nearly collapsed in the boss's office, saying he was extremely breathless, and they called an ambulance and just called it a classic asthma attack. And he was getting these symptoms every day, so he had to stop work. And it took about 3 years for his lung function to normalise. So luckily, he didn't have any permanent impairment, but only after probably 4 months of working at this place that he developed another 3 years of abnormality. So he obviously couldn't go back to work as a spray painter. And the only real way to protect people with spray painting is to have a large booth. And you can see here this guy's wearing a full suit with his respiratory protection there, and there's fans that have air exchange, probably one room exchanged every 5 minutes or so. So pretty much all the fumes get sucked out up there, and the workers are protected against the spray paint. So luckily this guy sort of went on, and I think he decided he's not going to be a spray painter anymore, despite a different place having this type of booth. Okay, now, so that's sort of occupational history. You probably won't see it a great deal, but this is something that is seen more, harder to recognise, and people can go on for years without knowing, that they've got an abnormality from usually a workplace exposure. And this condition came to light pretty much after 9/11. So they used to call it fireman syndrome. So you probably remember those terrible photos of when the Twin Towers collapsed and that great big cloud of smoke just covered half of New York City. So the first responders there, these firefighters, were in and amongst, you can see this is all the concrete dust that came down, and they, at the time, because it wasn't actually a fire, were only wearing these paper masks, and they had huge exposure to fine particles of concrete dust and everything else that was in the building as well. And they found that probably about 60% of the firemen, for about 2 days, started coughing. They were very short of breath, ended up in the emergency department. Then it settled down, and a month later, probably about 15 to 20% of them had ongoing symptoms of cough, wheeze, shortness of breath for about 12 months, and about 5% became permanently impaired just from that one high level exposure to noxious fumes. And unfortunately, there's no real treatment for this because it's not due to asthma sensitization like classic asthma. This is direct injury to the airway in that distal part that I showed you before, where it's 10 micrometers in diameter. So you get abnormal cellular change, becomes very irritable, where even laughing and talking can cause cough, and in cases can be permanent. So this is something called reactive airway dysfunction syndrome, and initially called Feynman syndrome. And I'll probably go through a couple of cases that I've done just to sort of give light to the varied types of people that I've come across. So this guy here, he was a plumber in the UK, and he was doing sort of a part work, part holiday trip around Australia. And he was working in the Gold Coast, and there was some waterproofing paint on the side of a building that he was told to get rid of. So he tried initially just sanding it off, that didn't work. He tried an angle grinder, that didn't work. And then the boss went out and got this sort of flamethrower thing, and he had to sort of stand on the ladder and just burn this paint off the side of a building. And this awful black smoke came from it. He told the boss of the job what was going on, and once again was just given some paper mask. And for 2 days he was doing this, and he just noticed probably about a week later he started developing significant cough, wheeze, shortness of breath. He went to the boss to tell him about it. The boss fired him, and because he was a casual labourer, he had no sort of recourse to sort of get this pursued, especially because he had to go back to the UK a month later. So I did a medico-legal assessment with him via Zoom with him in the UK. This is 2 years down the track. He's still unable to work, and when I was talking to him, he was still very breathless. He was coughing. He couldn't play soccer like he used to, and he found it difficult even running around with his kid. So that sort of 2 to 3 day exposure to this black smoke that came from this fire blasted paint that caused him permanent damage to his airways, which is known as reactive airway dysfunction syndrome, and there's no treatment for it. And unfortunately, it's under-recognised. There's a lot of GPs just sort of call it asthma and put them on asthma medications. Okay, and this guy here, he had symptoms at least 2 years, because that's when I saw him. He couldn't run, and his lung function had halved. So he had the lung function equivalent of an 80-year-old, and this guy was only about 42. Okay, so another case, had a volunteer firefighter. She was a non-smoker, had no history of asthma, and believe it or not, it is sometimes dry up here in far north Queensland, and the Atherton tablelands had a pretty mild winter. There was a lot of energy around there with dried up grass and so forth, and there was a large fire there. Everyone was wearing their respiratory protection. Unfortunately, at the time, this girl was not wearing a protection and just got out of the fire engine, and this sort of great big plume of smoke due to the wind just descended upon her, and she couldn't see anything for about 5 minutes due to the smoke being quite significant. This only went on for 30 seconds and then cleared up. She put a protection on, fought the fire, but noticed for about 2 days she was coughing and breathless, went to the emergency department. They gave her standard treatment with steroids and Ventolin, didn't really do much. And then about a month later, she developed significant cough, shortness of breath walking about 10 metres, and I saw her initially for about 4 months after this, and even 2 years down the track from the incident, she still, had significant cough walking from the reception room into the consultation room. And, all she wanted to do was be a firefighter, and unfortunately couldn't go back to it. And her sort of other job, she found it difficult, even though that was an office job, because she'd be coughing all the time in a group of people, and, they'd glare at her thinking that she had COVID or something, but it was just due to this RADS. So there's a lot of psychological impact to this as well. Another case 3. This is a guy that was tasked with getting rid of concrete flooring. This is a picture of him and his workmates there. He was jackhammering concrete in a closed room with no ventilation, wearing a paper mask like this guy here. He was a smoker, but this had nothing to do with smoking. But the trouble is the boss had just sort of claimed that because he was a heavy smoker, all of his breathlessness was due to that. Didn't have a history of asthma, and he developed this RADS, and once again, he was unable to work, and he sort of had to go into a disability pension at the age of 45 because he could only walk 5 metres before becoming very breathless. So he was permanently inhaled, and this was just from a 2-day exposure to concrete dust like this. So what this, now this is another sort of sad case of a guy that was 45-year-old machine operator at a coal mine. So there's stuff that's called coal ash, which is sort of a byproduct of when the coal's brought out. And this is very tiny particles here. You can see it all covering this guy's hand. And it's not just coal, it doesn't have hydrocarbons and silica in it. This has got a whole lot of other metals and heavy metals, light metals, calcium, phosphate, and this stuff sort of eats your lung away. So he was standing next to his cabin that he worked in, and on one of the towers there where they normally suck this stuff into, one of the valves broke, and they did something called venting, where they push a button and it pretty much blows all this coal dust out of the area. And no one warned him what happened, and probably for about 20 minutes he couldn't see around him. He was breathing in this stuff here. Management, of course, ignored it. Said, "Oh, look, that'll get better," and he was unable to work. And when I saw him, he couldn't even get off the chair without significantly coughing and wheezing as well. Now, I guess that's sort of a quick vignette of this, probably worse than occupational asthma, which is a subgroup of asthma called reactive airway dysfunction syndrome that unfortunately not many people have heard about. So I guess, it's less common than it was 20 years ago. This is the occupational asthma. But I think RADS is more common because people don't really attribute their symptoms or their impairment to one single inhalation event, but it is quite typical with the symptoms once you recognise it. But I think it is under-recognised, usually a late diagnosis. Usually the management of the company seems to ignore people. Luckily, most cases are reversible, although that can be from 5 to 6 months up to 2 years. But it's the sort of significant irreversible ones that are usually bad, mainly because people are in their prime of their job between the ages of 25 and 45 and 50, and they've probably got another 20 years of work left in them, and they're sort of rendered permanently impaired due to a bad event of toxic inhalation. So I guess that's just a quick rundown of occupational asthma and this thing called RADS, which I think a lot of people have probably never heard of, but it's certainly a common thing that we see, and unfortunately it's fairly depressing when we see people too.
It's pretty creepy.
Yes, I know.
It's really creepy, and we really obviously do not even realise just how prevalent it is and how available it is in so many different employment situations. So for some of those people who are quite young,
Yep.
here we go. We've got a question. Won't even worry with my question first. What do you advise for a new worker entering an at-risk workplace that is otherwise asymptomatic?
Yeah, so a lot of...
Sorry, but with the spirometry normal FEV1 and FVC, but FEV1, FVC mildly less than LLN, no significant bronchodilator response for monitoring only, barring appropriate workplace controls.
Yeah, so I think they're worth seeing a respiratory physician for assessment to see whether their spirometry is reduced. Because I guess if it's a baseline before they start work, maybe it's just to see why their spirometry is abnormal, whether it is from a history of asthma, smoking, or some other lung condition, and then use that as a baseline if it's, say, for a coal workers assessment every year, to see if there's a drop or so. Now, most places these days do have a strict protocol, especially when they're using things like coal ash and so forth of protection. But I think this was just a guy that was in the wrong place at the wrong time. which is unfortunate. So I think most places are fairly good. The larger companies are, but it's these sort of tin pot places where it's, one guy, wants that group of people to go and grabs a few labourers, wants them to, grind out all the concrete in a confined room, or the other guy that, some bloke just said, can you get the paint off the wall? So, yeah, it's usually the big companies are good. They've got good protocols, good occupational health and safety things against toxic fumes. But unfortunately, it's these sort of cowboy outfits that can cause problems. And they're probably more workers at risk because they're not joined to any union and they don't really have much of a say.
Wow. Yeah. I guess my question related to the fact that it seems to me that many of these people are quite young. And it also seemed to me that their recovery was pretty much non-existent. They either stayed bad or got worse. Is
Yes.
that accurate?
Yep. Yeah. So what happens? So if someone has a massive exposure, usually in the first 24 hours, you get very sore throat, runny nose, a little bit wheezy. Sometimes people go to the emergency department and just get some asthma puffers, and usually all that disappears after about a week or so. But then after about 4 to 5 weeks, you get this cellular damage in the lung, where you get thickened airways and fibrosis and scarring. Then they get the permanent symptoms of cough and breathlessness, which may or may not disappear. Probably most of it 6 months to 2 years, or probably maybe 5 to 10% is permanent. And there's no real test for this either. So spirometry is not very reliable because coughing and breathlessness is the main symptom, and it's usually at a part of the airway where spirometry is not sensitive enough to pick it up, and CT scan doesn't pick it up either. So it's really based on the exposure, history, and exclusion of other things. But it usually does go through the keeper as far as compensation goes. But even though, compensation doesn't fix your lungs, but it's better than nothing. But yeah, so it's hard to do a whole person impairment on RADS because there's no objective marker that you can say that it's mild, moderate, or severe.
Goodness me. Okay. Does anyone else have a question that they would like to ask of Dr. Vincent? If you do, unmute.
I have a question. I've unmuted myself if that's okay.
Yep.
My name is Roger, and in my practice in dust diseases, we have come across a number of RADS type cases and where the damage has been quite permanent. And then we also have occupational asthma type matters. Is it generally the case that the impact of occupational asthma is not as severe as RADS, and RADS is more likely to be more significant in terms of poor long-term prognosis, as opposed to occupational asthma, which can be reversible and sort of can subside over a period of time?
Yeah, that's right, because it's pretty much down to the cellular level. So with the asthma, there's certain cells called eosinophils that infiltrate the airway, and they're the ones that over time generally improve. And generally the symptoms are often mild, never severe, unless you get a flare up from a viral infection or something like that. Whereas the RADS, you get this different type of infiltration of cells which are permanent in the lungs, and people are very sensitive to even just taking a big breath in, where there are problems with sudden coughing episodes, or if they start doing exercise they become very breathless. So yeah, you're right. I think permanent RADS is worse than the occupational asthma that's long term.
And just one final question, if you don't mind. Reactive airways dysfunction syndrome and reactive airways disease, are they the one and the same, or is there a difference between the two?
Probably the same thing, really.
Okay. All right. Thank you.
No, that's all right. Yeah, they're horrible diseases.
Absolutely awful. I have one question from someone who was unable to attend today, and they were asking that in the same way that, for example, viral injuries or presentations in the throat can result in later precancerous changes to the esophagus, are any of these exposure asthma things likely to lead to precancerous or cancerous conditions of the esophagus or lungs?
Probably not the esophagus, but there are some carcinogens in, especially the coal dust, especially the heavy metals. I think there's mercury. Sometimes a silica as well, which long-term, so once you've inhaled it, it doesn't go out. So I haven't seen any cases, of lung cancer from rads, but there's probably need a latency period of about 40 years before it's picked up.
Great.
Yeah.
Awesome.
I guess the answer is it probably does cause cancer depending on what they breathed in at the time.
Wow. Not great, is it? Big message about occupational safety. Does anyone else have a question they would like to ask? No. Look, this is great. We're finishing up a little after time, but that's wonderful. Dr. Vincent, that was terrific. So informative, so interesting. We got one message here. Let's have a quick look. Thank you.
Oh, no worries. That's
Lovely.
all right.
Thank
No
you,
worries.
everybody, for making time to join us today. We look forward to seeing you next time. And take care. Look forward to the recording. And we look forward, of course, Dr. Vincent, to your third and final session in this series coming up. Have a
All right.
great rest of the day, everybody.
Thanks. Bye.